welcome to our Carers Lead Learning Network meeting. Um, it seems a while since we've had one, but I think it's about 7 weeks since the last one that we had. And we've got quite an agenda today. We've got some lovely guests. We've got Yvonne Walsh, who's our dementia specialist here at Carer Support, who's going to be talking about the work that she does with carers and dementia. And we've also got Sophie Skilton Green, who's from the Living Well program, and it's a program I've been promoting sort of quite a lot sort of recently. And Sophie is the Living Well coordinator. And then we have Victoria from Leecroft Medical Practice, who's going to be having a chat with Caroline and Leecroft, our spotlight surgery for this month. So, Yvonne, are you quite happy for me to hand things over to you?
Yeah, sure. I thought I'd use our slides that I've adapted a bit. Um, so is that I'll share those hopefully if I can.
Yeah, brilliant, if you can.
How's that?
Yeah, we can see that.
Perfect. Okay, right. Well, let's start at the beginning rather than there. Right. So is that okay for everybody?
Yeah.
Yeah, excellent. Thank you. So, thanks for having me. It's privilege really. Make sure we get into all the surgeries like this. It's brilliant work you do, you two. So yeah, dementia carer awareness. I thought I'd call this. And uh, yeah, and this is me. I'm Yvonne. I'm a wellbeing worker and the dementia specialism lead for Carer Support West Sussex. That's my email address. I can share the slides if you wish at the end. I've just a bit of background. I've been with Carer Support for 5.5, nearly 6 years now. I took it on as a temporary stopgap, but ended up staying. So it's a brilliant place to work. I love it. Um, I was learning disabilities specialism in that team to start with, and then when we moved to locality teams, I ended up being the dementia specialism lead. I've got lots of lived experience, but I know that that doesn't make me an expert in everybody's dementia journey, if you wish. So I thought we'd start with the actual facts about carers and how many there are. So in West Sussex, over 72,000 carers, 8% of the population, and then that means that 8%, nearly 1 in 10 of your patients will be carers. And then the equivalent number of cared for, probably, possibly. One thing that comes up more and more with us is that 71% of those are of working age. So, particularly with dementia carers, trying to work and juggling getting GP appointments and obtaining medication and things like that, it can be really tough. 26% are registered disabled themselves. So you've got that added bit on it. A third of those reporting day-to-day activities are very limited. So even them getting out, coming to the surgery and getting themselves there as well as they're cared for there can be really tough. And a quarter of carers report that they themselves are not in good health, and a third say that their well-being suffers. So this is where hopefully social prescribers and people like that can come in and support them. West Sussex carers provide the equivalent of £2.18 billion per year, or £16 million every day, the equivalent of that care. So they're taking on this role, and it's huge, particularly for those who are caring for people with dementia. We've got over 31,000 carers registered with us. And a good one there, 59% of carers have financial worries. So that's just a quick overview of carers and where they're at. So you've probably heard all this and you've had all this, but it's so important, particularly with older people, about identifying themselves as carers. And so many people that I talk to with that are looking after someone with dementia, they see themselves as just their husband, just their wife. They said their marriage vows in sickness and in health, but those were written such a long time ago, and probably didn't include looking after someone with dementia. And so they see it, and it's very difficult, that sort of where it gets so difficult towards the end, and that point where people are deciding whether the person with dementia goes into residential care or not. And that is such, I've been supporting a carer recently, and it's taken her really almost a year to make the decision, where her husband was just, he was, there were all sorts of problems, but she just couldn't just accept. So we have, there's two sort of like strands of it. In the beginning, people aren't identifying themselves. They just think, oh, things start changing slowly. Oh, I have to do this for them, I have to do that for them. But then right at the end, there's the sort of like, well, I can't stop doing this yet, or I promised I would never put them in a home. So there's sort of like the acceptance right at the beginning, and then that sort of like change to the care at the end. Yeah, so it can take up to a year, it can take even over a year. And the main point about that is that people, it they don't then access the support that they're entitled to. And we can do so much. So the top thing is that get them identified. Whenever you've got a patient with dementia, behind that person will be a carer, or at least one carer. Please make sure that you acknowledge, register, and support them. And a lot of it, particularly at the moment, we always say that, I think, but particularly at the moment, they are really missing out on some financial support that we could be getting, or signposting them to. Dementia carers in particular, there's that intense mixed emotions, guilt, anger, grief, and burnout. And some of this is the reason behind their sometimes lack of patience, sometimes sort of like abrupt manner. I've seen it so many times where they are just at the end of their tether, and dealing with someone at the surgery where they're, intensely worried about caring appropriately. It can make such a difference to their manner and all sorts of things. And there's this living grief, or anticipatory grief, that they suffer from, where we're the loss of the relationship and the shared life, to have your husband, wife, mum, dad, have that change in personality and not be the person that they were. And the changes in their cognitive abilities can really distress people. And then they're trying to, contact you and look after themselves, and it's really challenging. One of the key challenges, though, towards once it gets to mid stage or late stage dementia, is challenging behaviours, and that can be viewed so differently by different people. Some people might call the fact that someone wants to wander or purposely walk now, walk with intention or with purpose now, it's good, I tend to call it. And the social stigmas that are there. People can't come and attend their own appointments because they've got to bring the person with dementia with them, and so in the end they don't come. So ways around sort of managing someone with those sort of challenging behaviours. They might shout, they might sort of pick up things that they're not um, shouldn't be, but it needs managing by professionals so that the carers can access their own health and wellbeing needs, so that they're met. Um, the isolation and overwhelmed by their and their loved ones' unmet needs, and that's a huge phrase for carers. They say, oh, this isn't happening, that's not happening, I'm supposed to be getting respite, but they don't turn up, or they turn up at the wrong time, and all sorts of things, and those unmet needs of the carers and of the care for. Um, sorry. um, Caregiver stress, that extreme tiredness. And as I mentioned, this woman I was talking about before, she was on 24/7 vigilance. She could barely nap herself because her husband was just constantly on the go. Mentally, he was very far down the dementia line, but he was still physically big and strong. And she was getting very little respite other than from her family and support. Although what we've did and what we have done is put in, or lead her, guide her, signpost to extra services that a lot of people aren't aware of. Don't know whether you're aware of DOPAMs and all those sort of services where um, dementia carers are dealing with someone that with dementia, but that person has also got mental health issues, and it's those can be addressed, but sometimes they're not. It's just seen as a part of the dementia. Oh, they've got dementia, they're bound to be upset, aggressive, or whatever. But quite often, all of this challenging behaviour is due to unmet needs, that sometimes the carers themselves can't and never could actually provide. Um, right. So what we provide, meet the teams. We've got the helpline. I hope you're all aware of the helpline number. And so many people are just call in and just say, right, I don't know what you can do, but please help. And then if the helpline team can't help them directly, they come through the locality teams. And this is my bread and butter every day. This is what I'm doing. Within our teams, we're building the local partnerships. We hopefully can build on what Mike and Caroline and Anna have built up with this project. And that's when we're sort of making sure that referral pathways are there. We'll refer people to the carers health team and make sure that we often find that's really useful to get them in and have feet on the ground as to go and see what's going on at home for the carer with their loved one. And running groups and activities. There's our face-to-face groups are really popular. Activities that come up, particularly in Carers Week, if people can get respite, and that is a hard thing to get for those with dementia, particularly to get respite, just to go monthly to one meeting. And we supply carers with funding where eligible. And I think that's really important to make sure that carers aren't told now that, oh, well, you can get the carer health and wellbeing grant, or go to carer support, you'll get this grant for wellbeing. And now it's means tested. Well, it's not means tested as such, but it is done on eligibility now. So some carers are quite disappointed with that. But then there's the dementia lead, autism, learning disabilities, drugs and alcohol, and mental health specialist leads. And this is where we'll sort of we delve right into, make sure that locally we're linked in with all the dementia services, both professional, other charities, other support, to make sure that we can give as much specialist support as we can. We're linked in with Carers UK, who are that's where the Admiral nurses are still available, but online, not many face-to-face appointments now, other than within the nationwide branches. They're starting and gradually coming down the county where they're doing those face-to-face appointments, and those are always on our database that we got, our SharePoint site, and any wellbeing worker can link into that and find what support is available in their area or nationally for themselves and for their cared for. And the other thing, I did some work last year. We're linked in with Dementia Carers Count, and we've got a route through to free counselling for dementia carers. That's been really popular. A lot of take up with that. And something that I'd love to promote, because it doesn't, the numbers are going down, but the online carer group for people that care for someone with dementia, and when it's running, it's amazing, and we can also help with support to get people online. So we've got our digital champions, and the volunteers that can help you. Sorry, I'm talking to carers, that can help carers get online, even if that means we fund equipment and things for that. Yeah, so the care assessment team, a lot of carers say, right, I want a carer's assessment, and they're entitled to that. And a lot of professionals refer people over for a carer's assessment. But in the locality team, we will sort of like assess and see whether actually we can meet their needs within the locality team, and whether or not a carer's assessment, a full carer's assessment, is fully appropriate. But that does give people access to personal budgets in the form of direct payments. The hospital team. Now, this is really important for those who care for someone with dementia, that we are there in the acute and the community hospitals. And I'm doing some research at the moment about how much the butterfly scheme is used in the hospitals. And it's coming back that it's not, but it says on the websites that it is. So carers are sort of like expecting to have a butterfly on the cared for's notes, so that everyone knows in hospital that they've got dementia and that their care is appropriate for them. But it isn't consistent across the hospitals and even between wards. So carers could, sort of like, well, when he was in last time, he had a butterfly on, or a blue star or something on there, to identify him as having dementia, and then they get, well, we don't do this in this ward, and it can be challenging. It's a really challenging time for when they're in hospital. So please refer people and tell them about the hospital team, that they can come and use that. And then the support at home after hospital. This is really important for, and the hospital teams to ensure safe discharge for those with dementia. There was a spate a while ago where we had carers just saying that my care force just turned up at 9, 10 o'clock at night, and I didn't even know they were coming home, and I'm supposed to take them in at this time of night when normally they're, needing to sleep, or now they're going to be up all night, and yeah. So those sort of the discharge for people, hospital discharge is something that they work on, and the support at home after hospital to make sure that people with dementia quite often will go downhill, shall we say, in hospital, in that, if they're in bed all the time and their needs aren't being met and they can't eat the food or don't like the food, all sorts of reasons, they can really deteriorate in hospital. And it needs to be carefully assessed when they come home. And that's what the support home after hospital service do. And yeah, I mean, much as I sort of had planned, but I'm open to any questions from anybody, please. Shall I stop sharing for now, and then I'll
Yeah, that'd be great. Thank you. Thank you, Yvonne.
That's okay. Where are we? Stop sharing. There we are.
And we're back in the room.
Caroline. Hello,
Yes.
we're back in the room.
Hi.
Hi,
Hello, everyone.
Lorraine.
Thanks so much for that. Yeah, I'm just going to read out, I don't know if you've seen it. There's a question from Freddie
Oh, right.
in the
Sorry,
chat.
I wasn't looking at the chat.
He was unaware about the new eligibility for the Carers Health and Wellbeing Grant. So could you share a little bit of information about the criteria around that, please?
Yes, so it is financially based now. We have to ascertain, we don't do a full financial assessment, but we have to ascertain that the main thing is that the carer would not or cannot afford the activity for themselves. It's very much based on, if people are on benefits, then if people are on pension credit, if people are on universal credit, then that is sort of like an acceptance level, if you like. And then, but above that, we might sort of like just check how people do month to month, if they're struggling financially. Yes, Helen, yes, I'll send you this, we'll send you the slides. So that is the criteria. It is based on actual need and financial need, and that when that came through, that was really disappointing for us as wellbeing workers. We got so used to having doing it before the criteria changed, where people used to come back and say, oh, I'd like my annual sort of like little bit of money to go towards having my hair done or buying my gym membership or my, and now that's not there for people who could afford it themselves. So yes, does that answer your question, Freddie? I'm sort of
Yeah,
we can send over the sort of like official guidelines that we had sent out to us about, how it's being done now.
If you
but
don't mind doing that, that'd be great.
yeah,
So we
sure,
can share with our
We'll,
team.
yeah,
But
we'll make sure
like
that we send that
like
over.
you've said, it is disappointing news, isn't it? Because it does feel like a bit of a barrier for carers who may feel guilty to ask for support anyway, to then have to sort of feel they've got to meet a criteria for a bit of support might present another barrier.
I mean,
So yeah, it's a shame.
absolutely.
It sounds light
To
touch
that,
as well. It sounds like
sorry.
it's a light touch conversation about their finances.
Yes, absolutely. It's not in depth, and we can we tend to, because we use the carer star as, I don't know whether anybody's heard of it, but that's our main sort of forgotten my word. It's our main way that we sort of like we make sure we listen to the carer about their caring role, but we then go into about their health and well-being, how they're feeling, how they're managing at home, and this is all within this star. And it's difficult sometimes because and I've changed the way I work because the finance question was the last one, or the second to last one, and actually you can go through and talk to people and say, oh yeah, and they say what would really help them, and then at the end when you say, oh right, how are you managing financially, and they'll say, oh well, we're self-funding at the moment, we're paying for private carers or whatever, and then we're sort of like, oh, so I've changed the way I work in the financial conversation will come first, and then you can disabuse them of the fact that they won't get the carer health and wellbeing fund, but then you can carry on and see what other support is available to them, because it's not all that's there, and quite often, getting £250 towards something is a drop in the ocean compared to what people need. We can access funding for white goods. We can signpost them to Southern Water at the moment, who are doing a lot for people that are struggling financially. So there's other sources of funding there. Yeah, hope
And
that
I think,
helps.
Yvonne, you're right. I mean,
Yeah.
looking at the other sources of funding, I mean, we're actually going through sort of the changes now where we'd had like the option for the household support fund. It's now the crisis resilience sort of fund. So we're having to sort of like learn a new way of sort of like directing people to apply for the funding there. So it's,
Yeah.
it is changing. And what
It
we have to ask
changes.
people.
Yeah. We get to the end of the financial year, and the household support fund went. We were able to support carers with, substantial amounts of money to make sure they had their white goods. They had, we've had particularly dementia carers that are people coming out of hospital that have gone into care homes. Women, I know you're all over the county, but where my locality is Crawley in Mid Sussex, I've got carers that live in Crawley, don't drive, and they're cared for is put in a home in Horsham, the other side of Horsham, and it takes two buses, and these are elderly people themselves, so we were able to help with things like taxi fares and things like that. But at present we have to refer people to the community hub for this crisis resilience fund. I've got to get used to what it's called, and it's so different. And that's quite often what we deal with is expectations. People have heard from their neighbours or their peers that this person got so and so amount of money from us, but now we're sort of having to say, sorry, we can't do that now. Yeah, it's can be difficult, and it's worth being quite making sure that you're using language like you could possibly get some money from care support, but they offer other support as well. It's that language, isn't it, and expectations. Okay, was there any other sort of questions or anything?
I just wanted to say, Yvonne, it's really important while you're in this role, sort of as a dementia lead, because we know that dementia is going to increase.
Oh, hugely.
You hear about it, you've only got to pick up a paper or go onto the news, and a celebrity has sort of got sort of dementia,
Yeah.
and that hits the headlines there. But there's so many people that you don't hear about, but the numbers are going to go up.
Yeah,
So,
absolutely.
it's really important having these roles and sort of the connections that you have with all the services.
Oh,
So,
yeah.
thank you.
That's okay, thank you. I just to say on that about the celebrity thing, I actually watched um an information podcast from Dementia Adventure the other day with Barbara Windsor's widower, who is working with them and is doing podcasts and things to raise awareness and to talk about what it really is like. Yeah, and how tough it was. And even someone like that, he was so isolated. You know, people sort of gradually break away, fade away. They don't want to see this person. They want to remember them as they were. Well, good for you, really. But I'm living with this all day, every day, 24/7, and it's tough. It's really, really tough. So please support dementia carers with, you know, gaining access to medication, getting prescriptions, getting things sorted on a, you know, those things can just make it seem like small issues, but they can make a huge difference. So thank you. Stop now.
No, thank you. Thank you for coming and talking to us. Just to make sure. Yep.
Freddie's got his hand up again.
I'm
Yeah,
sorry, I know
please.
you've got other speakers, but it just came into my mind, Yvonne.
Yeah,
I
go
know
and go for
your
it.
locality is based up in Crawley, but I'm just wondering
Yeah.
how closely you work with Sage House down in Tangmere.
Oh, really, really closely. I've been working with, they've been trying to open a satellite up in Horsham. I don't know whether you were aware of that. They were trying to use Lavinia House up there to, you know, replicate what was down there. But unfortunately, that has sort of fallen through for various reasons. But they're looking at other properties. So yes, we are, and we will refer to Sage House. We will, you know, if the locality is appropriate, Chichester area, and that highlights the disparity between areas about the support that's available. In the north of the county, I work in East Grinstead. I run a carer group over in East Grinstead, and it's like the, you know, treated, and it's like the back of beyond up there, and you know, there's no respite other than private paid for respite. It's really difficult, and that, you know, postcode lottery is huge. But yes, Sage House, amazing. I've been down there a couple of times, and they actually will come out and do training for people. So and it's really, really good. So if ever you want training for teams, they are, if you're in that locality. Yeah, thank you.
More questions? Oh, the training is very good.
Oh,
Thank
what,
you,
from
Kimberly.
Sage House? Yeah, yeah. But there are other, you know, if you're not in that locality, other training from Carers UK, Dementia Adventure, you know, sort of national organisations. They've got good online, that they will offer training for professionals, but there's also good training on there for carers to do, to really sort of get them understanding what it's all about and what dementia is, and the differences, and he's not got dementia, he's got Alzheimer's, and that sort of like understanding of the wording. That's not the right word I need, but you know, those. Yeah.
Oh, thank you, Yvonne. Thank you for
Okay.
your time. And you're
No,
welcome to
thank
stay.
you.
I know we've all
Yeah,
got to
I
travel
would. I'd
across
love
for
to stay
training
on.
later on, but it'd be well,
Yeah,
you know,
yeah.
please
Well, I'll
do
see you
stay.
there. But yeah, I'll put myself on mute now, and I'll be carefully
Okay.
listening to everybody
Oh,
else. Thank you
lovely.
very much, everyone.
Thank you.
Thanks.
So for our next speaker, I'd like to welcome Sophie. Sophie's from the Living Well programme. Sophie, can I kindly hand over to you?
Yes, thanks, Mike,
Thank you.
and thank you for having me today. I'm just going to share my screen, so if you just bear with me. And I hope everyone can see that. So yeah, I am from the Living Well programme. I'm one of the coordinators, and I'm from the Sussex Community NHS Foundation Trust. Our Living Well course runs all across West Sussex and Brighton and Hove. So the Living Well programme is a free 6-week self-management course. It's for adults, anyone over the age of 18, living with any type of long-term physical or mental health conditions. We have participants with a wide range of long-term conditions, from diabetes, fibromyalgia, heart conditions, arthritis, depression, anxiety. They're just to name a few. Before I go into a bit more detail about the Living Well, I'm just going to gather your thoughts on a couple of questions that I have. So I'm just going to throw it out there if you want to sort of put whether you think it's A, B or C in the chat. But how many people do you think in England are now living with a long-term health condition? So you've got 10 million, 15 million or 25 million. So yeah, lots of C's, an A, C. Yep, you're right, it's 25 million. So there's an awful lot of people living with long-term health conditions. So my next question is, and what percentage of people with long-term health conditions report feeling confident in being able to manage their condition? And I've got 78%, 83% or 89%. Yep, fabulous. Everyone, yeah, A, that's right, it's 78%. So a little bit more about those stats and some others then. So the current issues. We are an ageing population and rises in multi-morbidity mean that 25 million people in England now live with a long-term health condition, and this is only set to rise. People with long-term health conditions account for 70% of all GP appointments and 50% of hospital activity. 78% of people with long-term health conditions have said that they're either very or fairly confident of being able to manage their condition. 22%, however, have said they are not very confident at all. So projecting these findings across all people with long-term health conditions results in a potential 5.5 million people not feeling confident in managing their issues caused by their illness. So over the last 6 years, starting with COVID, the numbers of people saying they are either very or fairly confident of being able to manage their condition has fallen by 5.4%. Over 50% of people have said they've not had a conversation with a healthcare professional to discuss what was important to them in managing their condition. So projecting these across all people with long-term health conditions results in 12.5 million people not having a conversation about what is important to them in managing their condition. So sort of bearing all this in mind, what is self-management and why is it important? So self-management aims to empower people with a long-term health condition to take control of their treatment. It's a set of approaches which helps patients manage their own health. This can be physical health, mental health, or both. So self-management involves finding out more about their condition, learning new skills to help manage their health, working in partnership with their health team, and choosing what is right for them. Why is it important? So people with long-term health conditions spend an average of less than 4 hours a year with their medical team. So having the right tools in place can really help them the rest of the time. They have potential benefits of self-management, which include increased control. Understanding their condition can empower them to ask the right questions to their healthcare professionals. It can help them save time and money. Having to take a day off arranging childcare while seeing a healthcare professional can be difficult. Reducing anxiety, knowing what a symptom or diagnosis can mean, can help reduce this. It can help the person feel more confident about what they need to seek help and ask the questions. Improved outcomes. People who are actively involved in their own care are shown to have a better outcome. So recognizing when symptoms are getting worse, knowing what to do and when to help can reduce the risk of serious complications. So having a better understanding of self-care, of self-management, is important. And this brings us on to the Living Well programme. So the Living Well programme is a self-management course for people living with any type of long-term health condition. It aims to help people to take more control of their health by learning new skills to better manage their conditions and to learn to live well better on a daily basis. The course isn't intended to replace medical treatment, but to run alongside it complementary. We are not a clinical service. Our course is delivered by trained volunteer tutors who themselves are also living with a long-term health condition. We don't discuss any specific health conditions. Instead, we focus on the problems and the symptoms that people live with and how they can manage these using self-management techniques. So as I said, we don't talk about specific conditions, but the symptoms. Many people assume that the symptoms and problems they are experiencing are solely due to the condition that they're living with. While a health condition can certainly cause pain and shortness of breath and fatigue and so on, it may not be the only cause. Each of these symptoms can by themselves contribute to other symptoms. So this is our symptom web, and we use this a lot during the course. So for example, we've got our health condition in the middle. We might have low mood. Our low mood can then cause fatigue, which then can cause stress and anxiety, which then can lead on to poor sleep. And in turn, this can make us experience sort of pain or shortness of breath and so on. And all these interactions of these symptoms in turn make our condition feel worse, and it becomes a bit of a vicious cycle. And this only gets worse until we know how to break it, have a bit of a circuit breaker. So for example, with myself, I live with migraines and I have a lot of muscular issues with my hip. I find when I have a particularly bad flare-up with my hip, I experience pain. This then leads to poor sleep, which has a knock-on effect as my stress levels and anxiety go up. And this then leads me to having a low mood. I then get one of my migraines and I'm back to poor sleep as a result. And it's just a bit of a vicious cycle that I go in. So for all our participants, the symptom web they might have will all follow a unique pattern to them. And they won't necessarily experience every symptom that we have on the symptom web. And also over time, our web might change. But by understanding their own symptom web and identifying the causes of their symptoms and recognizing how each symptom can affect others, participants can then learn which self-management tools will be effective in helping them to break their web. So I'm going to go on to our self-management toolkit. So we go into great detail on our course about the toolkit, and you may have noticed that there are a lot more tools in our kit than there are symptoms on the symptom web. This arms us with a variety of self-management techniques that we can try out to help us tackle each of our symptoms. So as you can see, whilst these tools are not rocket science, the Living Well programme will give the participants the opportunity to practice using them all. It will give them the time and space to try out and find out which one works best for them in managing their own health and symptoms. So for me, example, the tools I like to use are distraction, positive thinking, breathing exercises, physical exercise, and relaxation. And I use these ones on a really regular basis, and I find they really do help me manage my symptoms and to break the vicious cycle that I sometimes get into. Some of the tools I don't use as often as others, but I do use them when I need, such as sort of problem solving and goal setting. So a bit more of what we cover during our 6 weeks. So we've got all our topics here that we cover over the sessions. These topics all help to give the participants the skills and techniques they need to manage their symptoms. And we can break them down into 3 categories. So we have psychological and emotional, physical and practical, and implementation. So as you can see in psychological and emotional, we look at all these techniques to help us with functioning well and feeling good. So distraction, grounding. With our grounding session, we look at sort of grounding techniques like the 5, 4, 3, 2, 1 technique, of 5 things you can see, 4 things you can touch or feel, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. We also look at relaxation, which we do a body scan, which always goes down really well. It really relaxes people, and it sometimes actually makes them fall asleep. It's that good. We also look at a happy box. So this is for when people are going through sort of difficult emotions. We look at ways a happy box can help them, and it serves as a reminder of positive memories and a distraction during stressful times. And we often find the next week, on the next session, once we've spoken about a happy box, that they've actually gone back and actually made one themselves. With physical and practical then, we look at the boom and bust cycle during our fatigue and pacing session and what we can do to help prevent the exhaustion that comes from overexertion. We look at ways to get a better night's sleep. We always ask our participants on any tips they have to help each other. We find that our participants, they are a really good support network for each other, and it really makes participants make sure that they feel that they're not alone with what they're going through. And I also, whenever I'm on a course, I always find out new tips from people that I didn't know. So every day is sort of like a learning day. With implementation, we look at ways to help them put what they are learning into practice. So at the end of the 6 weeks, the participants write their own self-care plan. This is to help them sort of manage their health and well-being going forward once the course is over. So yeah, the participants really are a great support for each other, and they, as I said, they often share ideas and tips. It's a really nurturing and caring and safe environment for them. So one really important aspect of our course is goal setting. We talk about goal setting from our first session, and we talk about it every week. It's a really important part of a self-management course. So we go through the goal setting at the end of the session, and at the beginning of the next session, the participants feedback how they've got on with the goal that they had set themselves from the previous week. So we introduced it on week 1, and we asked participants what their long-term and short-term goals are. And then at the end of that session, they then set themselves a goal that they'd like to accomplish over that coming week. We asked them to set something that's achievable and that they're going to be able to manage. So for example, sort of reading a book 3 times that week, or taking a short walk twice that week. The aim is for them to achieve their goal, and then each week they build on it. When someone has a long-term health condition, we really must take pride in the small achievements that they accomplish. When we talk about goal setting at the beginning, we always like to show this image of the ladder with obviously the massive big leaps or the short steps. And it just shows how taking small achievable steps really helps get yourself up that ladder instead of trying to make something unachievable and just not being able to make it. Each achievement reinforces a sense of progress and builds on their confidence. So here's some feedback that we've had from previous participants. So these are some plaudits. So as you can see, it was a really enjoyable and felt that it was a safe space to share. It's been really helpful to meet other people with long-term health conditions. I feel less isolated. Meeting like-minded people has been amazing, and I don't feel like I want to give up anymore. But yeah, there's a sort of just some snippets, a snapshot of some of our feedback that we get. Looking at some sort of feedback, at the beginning of the course, we always send out feedback for our participants about how they feel at that time before they start the course. And then we ask them again at the end of the 6 weeks. And then again, we ask them after 6 months, we go out to them. So this one is the confidence to manage symptoms and prevent them from interfering with daily life. So on the blue is how they felt before they started the course, and the green bars is how they felt 6 months. And this is, their confidence. So as you can see, in all areas, their confidence has gone up after taking the Living Well course. In other feedback, we found that 98% of people were pleased that they had attended the course, and 98% they had benefited from attending the course, with majority of which was to a substantial benefit or above. Last year, everyone who completed and returned their feedback stated that they were pleased they'd attended the course, and when asked to rate their overall satisfaction with the course, 97% of the participants said that they were either satisfied or very satisfied. I'm just going to show you a video now from one of our tutors. As I said, our volunteer tutors all live with long-term health conditions, and they've all been participants on our course before they have come and been volunteers for us. They really are the heart of the Living Well course, and this is Katie's story.
So I originally signed up for the Living Well course back in 2023. That was through my social prescriber at my GP surgery, and I've been living with fibromyalgia and some other long-term health conditions for a very long time, and my social prescriber thought that the course would be quite helpful for me in my self-management journey of all my chronic illnesses. It was brilliant. I got so much knowledge and things and ways to support myself through doing the course, and through some of the other participants as well. They can be really key in helping and assisting and giving ideas, and the amount of help that it gave me and the amount of help that I could see it gave other people made me want to become a volunteer tutor. which I have been doing for about 8 months, I think now. I absolutely love it. It is so rewarding. Helping other people to manage their symptoms, and the feedback that we get after each course is just fantastic. So that just goes to show how much it really does help people live well, or as well as they possibly can, whilst managing chronic health conditions.
So that's Katie. I hope you could all hear that, but if not, there were the subtitles at the bottom. But yeah, our tutors, they are, as I said, they are the heart of our course, and they are such great advocates. So about the sort of course fundamentals, as I said, it's open to anyone over the age of 18 who resides in West Sussex, Brighton and Hove, living with any type of long-term physical or mental health conditions. Yeah, we don't talk about specific health conditions, but just the symptoms. So it's a 6-week course. It's once a week. We do 2 types of courses. We do them online on MS Teams, which is 2 hours a session. Also, if people aren't very, me myself, I'm not particularly IT, but people that do need extra help and support, we can offer them a pre-course call going through MS Teams, helping navigate any issues they might have. We also run courses out in the community, different locations across West Sussex, Brighton and Hove. So we have courses in Brighton. We've got one at the moment in Worthing, having one in East Grinstead in June. We've got another one then Bognor later the year, but we run them different locations, and they are a bit longer. They're 2.5 hours a session. It is the exact same content. It's just that we have a slightly longer break for all the participants to sort of talk to one another. It is self-referral. We do like participants to complete a booking form themselves. We can either send a booking form out to them in the post, or they can do it online, whichever is easier for them. So roughly we have about a maximum of 12 participants on any one online course, and we have 16 on a community course. We do have more courses online, and we have them at a variety of different times of the day. We have them in the morning or the afternoon, between Monday and Friday. All our community courses are generally run in the morning between 10 and 12:30. Here is our contact details. So we've got 2 offices, one in Horsham and also one in Brighton. Got our email, we've got a website. We've also got a Facebook page as well. And there's our QR code. And I've seen someone's asked the slides, so you're happy to send out the slides afterwards as well. But if anyone's got any questions, then please do ask. Hi, Freddie.
Me again. Thank you for. It's always really good to have a bit of a refresher on the Living Well program. Well, I've had some really good success stories with clients in the past. But something I've noticed recently is you've grown in popularity, and I believe there's quite a waiting list for some of your courses now, including the online one, which you only started during the pandemic, didn't you? So what does that waiting list look like?
Well, at the moment, it's just been sort of this year. As soon as we open up our new courses, suddenly the online ones are getting booked up within the space of just a few days, which hasn't sort of happened before. So we are looking at trying to put more courses out there. Just sometimes we just don't have enough volunteers to be able to sort of tutor the course. But at the moment, well, we do. I suppose we're trying to be fair as we can when we're trying to let people know, and it is sort of like a first come, first serve. But I think in the long term, we are trying to hopefully put more courses out there to try and cover it. Because last year we'd always have space, but it just seems to be this year, which is good. We are getting the people. Sadly, sometimes when the courses are full, they don't always turn up, which is then quite frustrating, because then that space could have been with someone else. Even though interesting, our East Grinstead course is really not being very popular. We haven't been to East Grinstead for a while, and we don't seem to be getting the numbers. So I'm hoping that the numbers will increase. But yeah.
Yeah, and you mentioned the course in Worthing and Bognor. I couldn't find that online.
Oh,
so have you got
so
those
the Worthing
dates?
one, that's actually, well, sorry, that's in progress at the moment. It's at the Findon. It was going to be in Worthing Town Hall, but sadly they couldn't accommodate us, so it's in Findon. The Bognor one we haven't started going out with yet. Bognor is going to be the very beginning of September.
Okay.
Yeah, that's the 10th of September until the 15th. But yeah, we haven't sort of opened up bookings for that one yet. And then
You'll send that out with your newsletter.
Yes, we will.
Cool.
Yeah.
Thank you, Sophie.
Oh, thank you, Freddie. Any other questions?
Just seen Yvonne saying that she'll promote it sort of with the carers groups. And
that would be great.
Instead.
Thank you. Yeah, and we welcome carers to come on as well for them if they want to come on it. Yeah, that'd be great. Thank you, Yvonne.
Sophie, it's not a question, it's a thought. Sorry. Just thinking, have you ever considered sort of self-guided courses that people could just log on to, I don't know, members portal and complete themselves? I know the power of it is the group. But,
yes,
cool.
We are looking into that. It's just with the trust, but that is something that we're really, really keen to do. So that is
nice.
That is something.
Lovely.
Oh, well, thank you for having me.
Oh, no, thank you for coming along. It's been really good sort of like to hear about the programme again, because I'm a big advocate for the programme.
So, well, thank you.
Yeah, so thank you for coming along. I don't think there's any more questions. Heather, did you have your hand up or?
It was mainly around, we have quite a lot of people where English is a second language in Crawley. So I was going to just ask, but
we have had people before with translators, but again, that is something, because we are trying to expand, is that we have also wanting to look at as well with people when English isn't the first language. But we have had a course before where there has been a translator.
Okay, great. Thank you.
Thanks.
Okay, well, thank you, Sophie.
Oh, well, thank you.
It's flowing lovely this session today, isn't it?
Yes.
It's been really interesting, sort of taking in all the information. So I will hand you over now to Victoria from Leecroft and Caroline. And Victoria is going to be our spotlight surgery and for the last part of the meeting today. So if I can hand you over, and yeah, thank you.
Thanks, Mike.
Hi, everyone.
Hi, Vicky. Hi. Yeah, so just a quick intro. Today's practice spotlight is going to be a little bit different from how we have traditionally done it, which is normally a bit of a Q&A between us and the practice spotlight. But Vicky and I were talking a while back just on one of our catch-ups, and the whole conversation really was about obstacles to encourage carers, I suppose, to access support that is offered at the surgery for carers. So Vicky's done a lot of work really trying to get in some great support for carers, and she's done a really good job with that. But then she's noticed, I don't want to put words into your mouth, Vicky, but I think I'm right in saying you've noticed that, you put this support in and then sometimes there's a bit of a struggle trying to encourage carers to come along and make the most of the support that's been put in. So Vicky created a little list of things that she's experienced at the surgery, and we're going to share these talking points, and we would really love, this is a bit of a brainstorming session, really. Our surgery, we wondered, are other surgeries experiencing these same sorts of barriers and obstacles to support carers? Or maybe you found a solution to a particular problem that Vicky's experienced, and you can perhaps share how you've got around this obstacle. So I'm going to share, is that about right, Vicky? Is that what we're talking about today?
Yeah, absolutely. Yes. And I think a couple of the other speakers have already mentioned about, barriers for carers regarding their own health and accessing medical help. And also Sophie and Yvonne have both mentioned, supporting each other, and I'm hoping this conversation will help answer a few of my questions, and it might also help answer some other struggles that people are having. So, working within the PCNs, I'm hoping we can come up with maybe some ideas that would help everybody, if that's okay.
Great. So I'm going to share, you're happy for me to share my screen, Vicky, and then
yes,
you just let me know when you're
no
happy
pressure,
for me
anyone,
to
take this
click
all in.
through.
It's more notes for me so that I know what we're talking about. Perimenopause brain is real and things disappear out of your head. So it's a list for me to follow. And I think what we'll do is
probably go through the slides one at a time, and then if anyone's got any input or insights they'd like to add, then please either raise your hand or pop a comment in the chat, and I think Caroline is going to keep an eye on the questions or any input that comes in via that.
Yeah,
so,
right, so let's go on to our first slide. So
how this all came about, as Caroline mentioned, was carer engagement. So like you said, there are a lot of support services and there's a lot of areas we can signpost to, but even when we do that, carers aren't necessarily engaging or signing up. And what flagged for me was when I was looking into offering carer health checks at the surgery, uptake was very low, and I was hoping we could maybe have some ideas around, what would be the barriers people face about making these appointments. We understand from a carer's perspective, it can be time, it can be energy, it could be not having someone to sit with their cared for. The list is endless, but we want to make it as easy and as streamlined as possible for people. So if you have any insights or suggestions around carers health checks in particular, that's what we're going to be talking about. So firstly, obviously we're supposed to offer annual health checks to our carers. This is for adults only, over 18s. But then I thought, well, actually, if we're doing that for our over 18s, what about our young carers? I know Carers Support West Sussex obviously have limited input with the young carers, and there's different services for them. But should they, if they're in a caring role as a young carer, should they be eligible for a health check as well? And what topics would be covered in that? And also who would conduct that? Because as a care coordinator, I can only assist people over the age of 18. So would it be best placed with a GP? And what sort of topics would be covered in a young carer's health check? Which leads me to then the invitation. How would we word the invite to adult carers and young carers? And if anyone has any letter templates that they use or have found useful in writing their own. I know Carers Support West Sussex have got the Carers Toolkit, and I was thinking maybe we could come up with a template to put on there for people as an invitation to come for their annual carer health check. And then what would be the best way to send this to people? I've mentioned a letter. It's my preferred contact method, but for a lot of people, it'll just go in the bin. As Yvonne probably knows, working with people with dementia, sometimes people with dementia can mislay or put things in areas where it wouldn't be seen necessarily by their carer. Is it better to send it via their preferred contact method, which would be maybe a text message or an email even? And then when they do come in, obviously the carer assessments, there is a health check template. We personally at Leecroft, we use System 1, and we have Arden's templates we can follow, which lay out the structure of the assessment. But I just wondered if anyone uses EMIS or a different template style, what sort of questions and things are involved in that? What does that look like? Could we come up with maybe a gold standard assessment that we're all following from the same page? So I don't know if anyone's got any feedback or insights they'd like to share on any of those points before we move on. Helen?
Yeah, we use EMIS at the Meadows surgery, and I invite for the carers, health checks at the surgery. Like you, I only tend to invite those that are over 18, but I do a soft touch check with the young carers, through their parents quite often, but just to make sure that they're accessing support, that they know where to get support, that sort of thing, and just to make sure they've not been or feel they've been forgotten. But the template we use is on EMIS, so for our health checks, and it's part of the, hang on, let me get it open. It's basic, in terms of blood pressure, weight, height, smoking history, drinking, the actual health aspect side of it is that kind of information. And then obviously with the actual carers check, health check, or the review check, which will be things like, have they have they accessed support? Have they been given information about carer support? All of that kind of information. Are they receiving any carers benefits, that kind of support, sort of separate to the actual health check, but it's linked. The two are linked together, so when you do one you can do both at the same time, sort of thing. Does that help?
That's really helpful, thank you very much. And I think someone popped something in the chat as well. Let me just have a quick look. Bear with me. Yeah, so Isla's mentions about young persons, social prescribers might be worth offering in with the support aspect of that as well, and then looking at a wider health check. So that's really valuable. Thank you both. Thank you for that. I think maybe move on to the next slide if there's nothing else, Caroline.
Yeah, has Helen's hand gone up? Is that a new hand, Helen, or is that your old hand?
No, sorry, that's me just not taking my hand away. Sorry.
Okay. Okay.
I will do that.
Let's go on to the next one.
Lovely. So obviously then who will conduct the health check? We mentioned roughly there about the GPs, maybe if it's somebody under the age of 18, but otherwise, as a care coordinator, I'm not currently offering this, but is it something I could offer? As we are following a template and I have really good clinical support where I work, fortunately, I know that might not be the case for everybody. Do we feel that's something that could sit within a care coordinator role? Or it has been suggested at our surgery that the healthcare assistants could offer this, as it's not too in-depth and then can refer onwards if needed. And then if we are bringing people in to see a GP or they're coming into the surgery, would it be worth combining this with the GP, with the annual review where they see their GP to discuss their medication? And then also, thank you, as Helen mentioned, should we be doing the blood pressure? Should we be doing a quick urine dip and a blood test? Does that all need to be included? Do we keep those appointments separate? So you'll have an annual review with your GP to discuss your medication and do all the basic obs. And then the carer's assessment is something slightly separate. Or could we combine it into one visit? So if the GP has certain questions they want to ask, could the healthcare assistant do some of it and then they can link in with the GP afterwards who could do the rest of it? Is it best to have these annually, or is it best for the GP to see them for their annual review, for their health checkup, and then just to help have staged regular contact throughout the year? Is it better to see them 6 monthly, or say you've got your annual health check with your GP in a few months' time, we'll be in touch, just so that we are making those soft touch regular connections and keeping an eye on people, especially if those are struggling or are in crisis? Do you think it would be worth bringing people in more frequently if capacity allows? So that's sort of the end of that slide. If anyone's got any comments or input they'd like to share.
Can't see any hands up.
No hands up.
No. Right. So thank you.
Okay, so these are all things to be thinking about. So any feedback, after the meeting, if anybody wants to maybe get in touch with Vicky via us or directly, then I'm sure that's acceptable, Vicky. Yeah.
Perfect. Yeah, happy to share my contact details. Thank you. Okay, and then just a few more things to consider would be how long would be sufficient for a carer's annual health check. I think we've suggested here at our surgery at Leecroft maybe 30 minutes, but I don't know if people, obviously some will be shorter, some will be longer, but I don't know if anyone's found that actually that is an appropriate amount of time, or people may generally need longer, maybe an hour. Annual invitations, are we sending those out? Who's reminding who when this appointment's due? I know we have recall systems. So would we send an invitation out on the month of their birth, or if people found that there's a better way to ask people when to come in? And then also just the purpose, just to make sure, as we've said, there are barriers, and the whole reason for this conversation is to discuss what are the restrictions for carer engagement. So is there a physical or mental health need? Could it be their workload? They need practical help. Do they need help with contingency planning? You know, there's a lot. I think something's come up in the chat just there. Bear with me. But yeah, the issue is exactly accessing appointments due to no respite. So this is all why we're having this conversation, so that we can come up with an idea that might help people. Helen?
Do you do home visits? Because I offer home visits for those that can't make it to the surgery, often for that very reason, that they've got no one to stay with the person that they're caring for. But I know that not everyone is comfortable doing a home visit, but I just wondered what the, what the general feeling is for home visits.
Yeah, definitely. So I'm not able to attend a home visit by myself. That's just a risk assessment that the practice have taken here. But I am able to go with another colleague. So I have a clinical nurse specialist who's on our frailty team, and we generally link up to do a lot of visits, and it covers a lot of this territory as well for carers. So yeah, home visit is a possibility, but then, like you've said, there are others who prefer that to speak more openly when they're not around their cared for. They feel it's easier to open up and share. So yes, I mean, maybe that is something that could be offered, is that it's their choice. We could put that maybe on the invitation. Would you prefer to be seen at home?
I don't tend to offer it off the bat, only because I do try to encourage them to come and speak on their own. But if it becomes apparent that there's a barrier to them talking to me, then I will offer it. But I don't tend to offer it straight up, because I prefer to be able to talk to them, on their own, as it were.
Yeah, and obviously that's got its own benefits as well, hasn't it, of bringing them in on their own so they can feel more at ease, hopefully. So thank you, Helen. Really valuable insights. Thank you. And then also the last point on that slide is just that if a patient does decline an invitation to come in for their assessment, are we recording this? Does anyone? I haven't looked, and I should have. This is poor planning on my part. Does anyone know, is there a code that we would use to decline an invitation for a carer health assessment? Should there be one?
Helen's nodding her head.
We have one. So on EMIS, I don't know how it is on System 1. It's not my primary system, but yeah, we have a code that we can put in, and we just, so long as we've shown that we've made at least 2 separate different types of invite. So we would start with the text and then follow up with a letter, and if we still haven't had any response, then we will code it as a declined, so that when I run my my lists, I can see who's at least been invited and in the last sort of 6 months or whatever. But yeah, there is a code, at least for EMIS.
Fantastic. Thank you. I definitely need to look at that. Thank you very much. There's a code for everything else, so I assume there would be. Thank you, Caroline. If we could have the next slide.
Yeah. Hang on. There we go.
Oh, we have a question from Isla. Bear with me. Do mention social prescribing support, as we can always explore barriers, accessing appointments and finding respite. Yeah, absolutely. Social prescribing is absolutely part of the signposting that I do here. And it's nice because actually Heather, who spoke earlier, she used to be one of our social prescribers here at the surgery. So it's nice to see Heather. So carers health team. Oh, they wouldn't acknowledge why they're declining appointments. Sorry, bear with me. That wouldn't acknowledge why. No, Yvonne, you're right. It wouldn't.
Does that make sense? Because yeah, it's sort of like declined, and it's like, well, not for you know, not through lack of trying or through, you know, wanting it or needing it. It's, you know, I can't come, I can't leave them. You know, and I think carers feel like that they're sort of, you know, oh, well, they've said I couldn't, I wouldn't go to the meeting, or I wouldn't go to this appointment, but it's not wouldn't, it's couldn't, you know. So yeah, I know you're all aware of that and really care, but it's just, you know, those
No,
sort
of
of like
course, but
those
that's
codes can just make it like, oh, decline, you know, and that rather than the background of why. And I think that idea of social, you know, offering then the social prescribing or having a home visit, I mean, that would just be such a relief to a lot, you know, lots of people. But again, it's down to capacity and money and staffing and all that, isn't it? Yeah.
and
Okay,
you're
thanks
right,
for listening.
and I
Thank you.
appreciate that, you know, it's not going to be a one size fits all. It never is
No,
in our job.
no, it's so
But
hard.
you know, if something works for the majority, we can start there,
Mm,
and then
yeah,
hopefully
great.
uptake will be better. And then what can we do to improve it going forward?
Mm,
Caroline,
thank
sorry, I
you.
think there's a couple of
Helen's hand is up again. I can't see everybody, so I need a bit of help. Oh, I've got two
Oh,
people's
okay.
hands up now. So
Go on.
yeah, because I've got the slides
with
up, I
Helen.
can't see all
Sorry,
the people.
mine was just a very quick one. I mean, that was it's a very good point. I would never want to just put someone as a decline just because they haven't replied, you know, and that's it. Then they don't get looked at for another. However, often you can see other sort of, when you're looking, because we always look at the notes, you know, to see what contact there's been. Has there been any contact? Has there been any clinical contact? That sort of thing. You can often get a sense if someone is under pressure. If I'd had no contact with somebody at all for like several different invitations, I would be trying to contact them on the phone. I would be, you know, trying to speak to them, because that would ring alarm bells if we're not having any kind of contact with them. But often if they're seeing that they're coming in regularly, they're being seen by other health professionals, etc., and you can see on the notes, you're less likely to have those concerns, unless the issues are clearly related to their caring, you know, situation. You at least know that they're being seen, you know. But yeah, if no one's seeing someone and you know that they're caring for someone, I would make more effort, definitely, because and that would include the social prescribe, you know, as well. We would work as a team to try and, you know.
Amazing, thank you. Thanks, Helen.
I don't know whether
And
you've already read the questions out on here or comments. Sandra said that you can put the reason behind the read code on system 1, which can be used to explain the reason. And Joe Stenin from Ada Health Partnership says, yes, you can add the details on EMIS as well. So,
okay, fantastic. Thank you, everyone. And Heather, did you still have your hand up?
Yeah, I don't know on your systems whether when they've been identified as a carer, whether the question's been asked, how would you prefer to be contacted? What's the best way? And, you know, how many times, kind of thing. Because sometimes, yeah, if it's declined, it might be that they don't want the service, and that's absolutely fine. But if, you know, if you're emailing people or whatever, and that's not the right way to approach people. So I don't know if that's already identified.
Thank you. That's really good. And that actually brings me on to the second point on this slide, which is maybe a carer survey would be, I know it's going to sound like we're creating more work, but maybe, you know, getting the feedback from the carers themselves, just a quick survey, which we could send out via text if that's easier, or when they come into the surgery, just ask them to do a quick tick box, just to help them know about any reasonable adjustments that we can make to make this process easier for them. You know, what's required. That is, you know, we're highlighting personalised care all the time. So if we can ask carers what would make this process easier for them, why not try and adapt it, even if it's just a tweak here and there. So that comes down to preferred contact method as well. So thank you. And yeah, and then just to say, really, I know we're close on time, but the whole reason this came about was because we have the carers health team come to Leecroft once a month, and obviously they offer their own assessments, but I've been struggling to fill these slots. It was three per month, so it was one afternoon, 1 hourly appointments. Liz Lavery, I'm sure some of you know Liz from the Carers Health team. She'd come in and do a carers assessment to see what practical support can be offered as well. And I'm just worried that, you know, we've already now gone down to two slots in one afternoon from 3, and I'm just worried if I don't fill these that it's a service that we could lose altogether. And it is so valuable. We've got an ad hoc clinic coming up with them in May, which for some reason the ad hoc one has filled quicker than any other planned one. So maybe it's just a case of preferred dates not being suitable. Perhaps I could look at changing that. But yeah, and I just worry that there's so many valuable services and so much support. I don't want people to miss out and we lose the services because not me necessarily myself, but we're not offering in a way where people can understand and accept what's being offered to them. So was that everything, Caroline? Have we got more?
No questions about this around the Carers Health team? No. Okay. One more, I think. Yeah.
Yeah. So just really quickly, we've got a really valuable patient participation group here at Leecroft. They're very hands-on, and I know that's not the case in all surgeries, but Caroline and I had a discussion and wondered if having the PPG available to help manage a carers register, or I know, Caroline, you've come along to coffee mornings at Leecroft, which has been run by our PPG, and added in some content about carer support and services that are available to them. So it might also be like a win-win if you can get your PPG involved as well. It keeps them happy, and carers know and might recognise people within the PPG that they're, you know, happy to speak to. And again, how often do you check in with the carers to see if they're still in a caring role? At the moment, I'm in the process of going through updating our carer register. But has anyone found a useful or the best way to check in with their carers and just see maybe someone's passed away, maybe someone's gone into permanent care? Are they still in their caring role? How often would you be checking to see, is it done yearly at the assessment? And that way we keep the register up to date by then coding if they're no longer a carer. Has anyone got any ideas, insights or questions around that? Helen, yes, please.
Helen.
I feel like I'm really sorry. It's
You're
just
star pupil, don't worry.
It's just this is one of, you know, I'm passionate about carers, and I get I'm very protective of them. But yes, it's what I do is, I don't know, again, system 1, so I'm of no help to you on system 1 whatsoever, sorry. But on EMIS we can run a report which will pull up those that are coded as carers, and I run that every month. And then all I do is you can then ask for any that have not been, or new ones, you know, ones added in the last period. So it will only give you new people that have been added, so you can make sure you're monitoring those. And then the admin team here pass through any notifications of deaths, you know, situations like that going into care homes. They notify me by a task, and then I can then look and see what did they have a carer, who was that person, you know, blah blah blah, so that hopefully it's not foolproof by any means, but it just adds another sort of layer, you know, to helping reduce that. So I mean, I've got another colleague who we work alongside, who obviously Caroline knows well, Ruth. So we're both the care coordinators, but we job share. So we have like a care coordinator task button, and the staff just they link us in with discharge summaries, death notices, you know, moving, things like that. And that's become part of their normal process, so that we automatically get notified, things like DNARs, respect forms, you know, things like that. And it's proving to be very helpful in terms of monitoring those people, obviously where their statuses and situations have changed. So it might be worth maybe talking about with your admin team to see if that's something that they could do. So
thank you. Yeah, that's a really good idea. have one for notifications of death, and I will then go in and do that. Obviously, there are other areas as well where people might find their carer status has changed for another reason. But yeah, definitely that's the starting point where I started with. That was with notifications of death, because that's the easiest one to update for the carer and the cared for. So thank you. I think there was something in the chat. Bear with me, just gonna have a look. Joanne. Oh, I've got one before that, sorry. Are the carers health team appointments on your website? Are they available to book online? Yvonne, no, they're not actually. They're ones we kind of offer in-house, if that makes sense. And they're not available to book online, but maybe they could be. That's a really valid point. Thank you. I'll see if we can get that added to the online appointment system. And then Joanne, we have processes for any deaths, carers and cared for. Yeah. EMIS runs a report on the carers register, run bi-monthly and then checked. Fantastic, thank you. I think Melissa's just typing a message. And then we're about there, I think. You have another, okay, lovely. Thanks, Melissa. Yeah, I think we've all got other places we need to get to, but thank you very much. Thanks for everyone's input on that. That's really helpful and give me a good starting point. So thank you.
Thanks, Vicky. I'm going to stop sharing. Great. Thank you so much, Vicky, for sharing your questions. Yeah, I don't know. I think maybe people will ponder this a little bit. I mean, if anybody wants to give it a bit of thought and then maybe contact us, myself or Mike. Vicky, you're happy for us to share your email, are you?
Yes,
your contact
please.
details,
Yeah.
so people can contact you directly if there's any kind of
very
thoughts
grateful.
or follow-up that comes out of this. So thank you so much for everybody's attention, and over to you, Mike.
Well, that's just been so good sort of this morning. This meeting has been sort of amazing with, you know, I want to thank Yvonne, Sophie and Victoria, particularly as well, sort of the discussions that were sort of like going sort of at the end as well. That's something we should do probably more often. And if you think you'll benefit from that, to have those type of discussions sort of within our meetings, maybe we can sort of like think of some questions sort of like for the future, like Caroline was sort of saying, but that was really good. So all is left to say is enjoy the last part of your week, and hopefully you're all off for the bank holiday weekend and haven't got to work at the weekend at all. Yes.
Yeah.
Now, I've looked at the weather. The other day it said sunny, then it said rain, and the cleaner here at Dublin said that it's going to be sunny this weekend, so I'm going with that one. So hopefully it's going to be lovely. So have an amazing weekend. We will be sending out a date for the next meeting. We've just got to agree which day it's going to be and who's coming to it. So thank you everyone for attending, and take care. All right. Bye.
Bye.